I'll start by welcoming you on behalf of the RSS official statistics section to this meeting about the beta version of ONS's Health Index, and this is part of its consultation process. So particularly, as you will hear from our speakers, they're very anxious to get feedback from individuals and comments about how they can take this index further. Before we go on to the subject matter, we have got some housekeeping points. Firstly, that all participants, apart from the speakers, were muted during the webinar. So if you want to submit questions, submit it via the chat function, which I think you can find quite easily. And please put question at the start, and I think it may not be, we've got on the slide the speaker to which it's directed, but in fact we just have the two speakers, so they may choose between them who's going to answer it. And please don't take any photos or screenshots. The presentations will be available afterwards on the RSS website, and also this meeting's being recorded, so there will be a YouTube available. And so if you have colleagues who missed it, please draw their attention to it, and we'll be publicising this fact that it's available. Now, we've got two speakers, and they're going to speak one after the other without any gap in the middle, and then we'll have questions on both presentations at the end. And as I say, please put your questions in the chat function. To introduce our speakers, Maya Glickman's Head of Health Analysis Methods and Data Quality and International Engagement at ONS. He's worked at ONS for 20 years, so if you know ONS's work, you'll have seen Maya's contribution, particularly on socioeconomic health inequalities and geographical variations. And before that, he worked in academia and the NHS, so he brought a broad experience to ONS. Greg Seeley leads on the Health Index and health projections. He's a Government Statistical Service statistician and previously worked in the Department of Health and Social Care and DWP. Of course, in the past year, he hasn't just been working on the Health Index. He's produced analyses of excess deaths for SAGE and the government's response to COVID-19. I think most people in ONS have been informing the government's response to COVID-19, often on top of their existing work. Anyway, we're very pleased that they've got time to come and speak to us today. So I'll hand over to Maya, who will speak first.
Okay, thank you, Alison. Let me just see if I've actually got control of the presentation now. How do I move to the next slide is the question. Has that worked?
Yeah, that's it. We hear, yes.
Okay, thank you.
You're away.
So I'm going to give a brief introduction about the Health Index, and then Greg is going to go into more detail and give a demonstration of the beta version and what you can do with it. And then after that, it's very much about questions, discussion, and getting your input into the consultation, which is still going on and will end quite soon, and which will then lead to a final version being published. So, introduction. The background to this, I think some of you will know, comes from Dame Sally Davies, the former Chief Medical Officer at DHSC, and her 2018 annual report. And she was very much looking at health, looking at the future of health and health policy, and how health can really be integrated into policies as an important aim of government. And what she said is, we need some kind of new indicator which will track health in a multifaceted way that recognises all the different kinds of determinants, but which will also be a kind of index that will go up and down and people can follow it. Those two things, the lots of information on health and the easy to follow index, are the kind of opposite poles which determine how we've approached the health index. As you all know, there are lots of existing sources of health data. This is just an illustration of one, PHE's fingersnips tool. There are other data sources of various kinds, for England, for the UK, internationally. And they're extremely valuable tools. They provide lots of in-depth information, lots of detail, lots of things which may be actionable about local level on specific subjects. That's not quite what we're trying to do. Then there are other things. There's things like the FTSE 100 index or GDP or various other measures. And these are things that the public see, that government and decision makers use, and they're expressed in a simple way. They go up or they go down. It doesn't really matter that most people don't understand how do you calculate GDP. The fact is people know it goes up and it goes down, and basically when it goes up it's good, when it goes down it's bad, and you can assess the impact of different policies on that. You can assess what that means for the country. What we're trying to do is take the best of those two approaches. The headline measure, which is simple and everyone can see it going up and down, and the kind of toolbox of indicators that gives you lots of detail and makes things actionable. We're trying to bring these together, and that's what the health index is all about. So what we want is something which the media and the general public can use, a headline measure. This tells us health is getting better. This tells us health is getting worse. And then break that down to some extent. Well, why is it getting better? Why is it getting worse? Policymakers should be able to use it to identify what are the areas for improvement. What is the impact of this policy I'm considering going to be? There are things people have to appraise in their policy proposals, environmental impact, legal issues, and so on. We want the health index to be something that people will have to appraise and say, how will this make the health index change in total or in its different domains if we implement this policy? And of course, to be a tool for all kinds of other people, academics, analysts of different kinds who are interested in health and how it changes over time. So Dame Sally didn't want this to be a Department of Health endeavour. She wanted it to be independent. So she proposed it to the Cabinet Office and ONS, and it was agreed that we would take this development forward. We then brought together an expert advisory group containing academics from various different departments, some people from local government, from public health, different partners across government. We started discussing the concepts and the issues and made some progress. It was decided last year, I don't remember exactly when, kind of in the middle of the year, that rather than our original plan, which was work it all out and then publish, what we would do is we would publish what's nowadays called the beta version. So it's a working model showing where we've got to and asking for comment on how we can finalize it and improvement. And so with a streamlined advisory group, we kind of rushed the work forward as fast as we could. And you've now got the beta, it's out there, people can look at it and use it. And then this consultation will allow us to refine it. The overview of the structure of the index, and Greg is going to illustrate this in practice. Firstly, the Dahlgren-Whitehead diagram that you all know, the concept of the wider determinants of health is absolutely central to what this is about. We're not just measuring health, we're measuring healthiness in a broad sense. So we're actually bringing all the wider determinants into into the structure and the interpretation of the index. The way that works is there's within the index 3 top-level domains, and you can see this on the right. And we've headed those to be easily understood by everyone: healthy people, healthy lives, and healthy places. And you can quite easily visualize a mapping of that to the wider determinants of health. What is primarily something at a community level, at a place level, what's something which might be behavioral and lifestyle, or it might be exposures that affect the individual or the household, and what are the things that are really health outcomes in the conventional sense. Then we've divided each of these top domains into subdomains. For example, healthy people, there's mortality, mental health, physical illnesses, and so on. And then under these, we've produced specific indicators. And then for these indicators, we've looked around, we've looked for the best sources of data, and we've applied criteria to what data should be used. It has to be data which is reliable, which is regularly available, which comes from preferably a government source, but it doesn't have to be a public sector source, something which is readily available, which can be disaggregated by area and so on. And again, Greg will talk a bit more about this. So that is an incredibly fast whistle-stop tour of where does the health index come from and what's the idea, what's it for? And now I'm going to hand over to Greg to give you a lot more detail about what exactly have we done and what does it look like.
Thanks, Maya. I'm just going to take control of the slides, and hopefully that's changed for everyone now.
Yep.
Brilliant. So I'm going to tell you about the methodologies we've used and have a demo of the data visualization used to explore the health index further. As Maya's touched on, we did a comprehensive review of the data landscape for health across the different concepts which fall within the definition of health we're using. So following the Dahlgren and Whitehead model, and also remaining consistent with the World Health Organization definition of health, which broadly is just avoiding using the absence of ill health as our only measure, because we want to capture these wider risk factors. We had some very specific data inclusion principles in order to make sure that the index was meaningful. First is we needed a time series. It was an option to present the index just with the most recent year at time of publication and say, ta-da, the value for the health index is 8 or whatever. But that wouldn't really be meaningful and it wouldn't put results in a context. So we knew that we needed to have a time series, multiple data points. So on our first presentation, we're able to say, in recent years, health has increased or declined according to the index, and this is driven by changes in these specific indicators. So for the beta version, we're looking at 2015 to 2018. Some of the indicators we've selected are available further back than that, but we wouldn't be able to produce the whole index further back. And the plan, of course, is to update these with newer measures as they're available to present beyond 2018 in the future. The indicators needed to have a clear direction of health improvement. Many of the sources in tools such as Public Health England's fingertips do show information about health, but it's not immediately clear whether a movement in one direction necessarily means that health is improving or declining. And in order for this index to truly measure health, we needed to limit it to indicators which allowed that. A large question within this was whether we captured incidence or prevalence for certain conditions. For example, if we were to include prevalence of dementia within the index, if dementia prevalence increased, that would technically look like health was worsening. But if it was increasing because our management of dementia had improved, so people were living longer with dementia, then that shouldn't be seen as a worsening of health if that prevalence is increasing. So we had to be very careful to make sure that the variables we'd selected were meaningful in, if they change, what does that mean for health as a whole? We needed the index to be available at subnational level so people could compare their local areas, and so it's useful to understand inequalities in the country as to where health issues are occurring and where they're not occurring. So the index beta is disaggregatable down to upper tier local authority level. We've consulted, and I'll say this later on when talking about the consultation, about what people would like most from the index, and the most common feedback we've had so far is, can we disaggregate it to lower geographies? So this is something we're exploring at the moment. Similar to the incidence versus prevalence comment, we wanted to make sure we were measuring health rather than healthcare activity or health services. Another example there might be eligibility for adult social care. If government policy changed and more people became eligible, suddenly more people would be receiving social care, but that doesn't actually mean that their health had got better or worse, just that the criteria for receiving that had changed. So we needed to make sure that we were measuring health and not trying to measure the health service as a whole. And finally, for the beta, our inclusion principles include data that are publicly available, but this was only due to the time constraints, and we're happy to explore other sources and are exploring other sources at present for what we can include in the full version of the index. Overall, this gave us 58 total indicators, and I'll summarize the domains and subdomains they're organized into a bit later on. For actually combining these indicators into an index, there were certain things that we needed to be able to do. One was have a national figure that could be tracked over time, so we could understand relative and absolute changes in the score. Similarly, we wanted to understand relative and absolute differences between different geographies, and then we wanted to understand for those geographies over time as well. Another index which many people are familiar with is the index of multiple deprivation. This gives each local authority a score, but this is based on their ranking. So if their score changes from one year of IMD to the next, it doesn't necessarily mean that their deprivation has got better or worsened. It just means that their position within the rankings has changed. And similarly, the IMD doesn't create a single England figure because it's looking at a ranking of local authorities. So we were a bit more limited in needing these comparisons to be possible. There were still options for different methodologies, but there weren't as many as there would have been if we were limiting the number of comparisons we wanted this index to achieve. So now we had all of these indicators. There were several of your typical data cleaning and scaling steps involved. For our imputation, we had a few different approaches, all quite simple for now. If there was a missing value for any UTLA and we had values either side, we would use linear interpolation to fill in those gaps. If we had a missing value at the start or end of the time series, we would replicate the closest adjacent value for that UTLA. And then there were a few figures which were suppressed. Some, if it was due to a small numerator, i.e. there were too few cases to report in some of the indicators. And in that case, we matched that value to the lowest value available and presented for any other UTLA. And if it was suppressed due to a small denominator, so a small sample size, we replaced it with the median value instead. There were only a few cases where we had information missing for a UTLA for all years. And in those cases, we imputed the mean for the region, but this was only necessary for 2 UTLAs within one indicator. So most of our imputation could be handled very simply. Even though we're looking at UTLAs, we had to exclude the Isles of Scilly and City of London, which is quite typical for this sort of analysis, because they weren't reported sufficiently across the different indicators within the index for us to show anything meaningful for them. Too much of it would have been imputed information. We scaled the data so everything had a consistent direction. So in all of our indicators, a value increasing means that health is improving. For example, where we have information on smoking prevalence, where that goes up, that should signify that health is reducing. So we had to reverse the direction of that of indicators like that. And we addressed skewness and kurtosis in our indicators with some functional transformations, picking the transformation from some commonly used ones such as log, square root, cube root, by looking at which one of those best addressed the skewness and kurtosis. But for the majority, there was a log transformation in order to turn the raw data source into our indicator and reduce that kurtosis and skewness for factor analysis, which I'll say a bit more about in a moment. And as far as standardization goes, again, we were limited by the number of comparisons that we wanted to make between the index score as a whole, its disaggregated topics within its hierarchy of health information, and also its disaggregation of local down to local authority level. So we used a time series standardization, which COIN, the OECD Centre for Composite Indicator methodology, recommended, where we calculate the mean and the standard deviation for each indicator for a base year, in this case 2015, and then apply that mean and standard deviation for the whole time series. So everything is based around a base year of 2015 having a score of 100, and a score above 100 in any year means that health is better than for England in 2015. Any score lower than that means that health is worse than England in 2015. It's also been scaled, so if your score is 10 points higher or lower than that 100, that indicates that you are one standard deviation better health or worsened health than that England base. This allows us to make those comparisons across time and only change the back series when the reference year is updated. And all of these are calculated at our UTLA level, and we aggregate up to region scores and England scores using the population size for each UTLA. So a UTLA with twice the population of another will have twice the weight when turning this into the full index score. I mentioned factor analysis very briefly. Factor analysis is how we calculated the weights for individual indicators and how we grouped the indicators into their individual subdomains of topics. We had conceptual ideas in advance for what we wanted the index to capture and our indicators that would inform each of those, and these were checked with our expert group, both when originally working on the full health index with the much wider group, and again building on that feedback with the more streamlined expert group when developing the beta, to confirm that we were capturing everything on health that we were aiming to. Factor analysis informed our groupings, but we weren't beholden to the results. So for example, in our healthy places environmental information, a lot of indicators were correlated if they had similar patterns of a rural-urban split, or if they favoured London or didn't favour London. There were very clear correlations there, even if the indicators weren't actually thematically similar. So we made sure that we were grouping things inspired and informed by the factor analysis, but diverting from it where that was sensible for understanding of the index as a whole. I'm not expecting you to be able to read those labels on the left-hand side of this slide with the heat map, but it gives you a sense for how we organized our indicators. So this is a correlation matrix of all of the indicators within the healthy people domain, and we've organized them roughly into what the different clusters or the different factors appeared to be. So each factor would be a separate subdomain, and those are listed in the boxes to the right. You can see that there's a box called Other. These are indicators which didn't fit neatly within one of the other factors. Even if we tried to add them manually and force a factor to a certain number of solutions, they wouldn't sit within that. And how these were treated varied a bit depending on what they were. So for example, you can see diabetes is in here. We tested diabetes as an indicator in the healthy lives domain instead. So that's individual circumstances and whether it was more a risk factor for other conditions, or if it sat better with those than it did with some of these physical health conditions themselves. And it did sit better there in the factor analysis. So we've included it within that domain. And all of these are still subject to change between beta and full version, based on the evidence available to us and whether we get different results if we change our indicator or change our data source informing each indicator. In some cases, we removed one of these indicators from the index as a whole if it didn't fit neatly within the factor analysis, but this was related to our weighting process for the beta version. So in the beta version, every domain, the 3 domains of healthy people, lives, and places, all have a 1/3 weight towards the overall index score. And within each of those domains, every subdomain has the same weight. So here where you can see 5 boxes if you exclude other, each of those 5 weighs equally or contributes equally to the healthy people domain. So mental health has 3 indicators within it, but it represents 20% of the 20% of the healthy people domains, 1/3 of the overall index. In some of these places, it's important that these variables don't produce a factor with other variables, because it suggests that they're measuring something different. And if we see them as relevant to health, then we wouldn't want to exclude them just because they didn't correlate with another measure. But where for the beta version, we had equal weighting for subdomains, and this is something we're looking to improve for the full version, it didn't make sense to include some of these as their own subdomain. For example, here we have other mental health conditions, which is conditions such as schizotypal ones and bipolar disorder. This didn't fit neatly with mental health or with the self-reported well-being measures, but if we had it as its own separate subdomain, then that would make 3 of the 6 in healthy people related to mental health and well-being, meaning that they had 3 times the weight that mortality did towards the overall score. So these were considerations we made when looking at the weighting for the beta version, but we can look at these in more detail with more sophisticated weighting for subdomains later on. And the weights for each indicator within each subdomain are based on how much of the factor variance they explained. So you can see here for the 5 subdomains we just discussed, the weights are broadly quite consistent across the subdomains. In some cases, across the indicators within a subdomain, sorry. In some cases, there are some larger differences. So for example, in the mortality one in the top left, avoidable deaths and healthy life expectancy contribute a lot more to that subdomain's overall weight than infant mortality does. And finally, one of the most important findings of all of these are the total subdomains within each domain. So healthy people has the 5 subdomains shown here of mortality, physical health conditions, etc. Healthy lives has 7 and healthy places has 5. And again, all of this will be revisited following consultation feedback, new things we're adding to the index, and improvements to our subdomain weighting approach. So what have we released on this? As our outputs on the 3rd of December last year, we released an article explaining what the health index is aiming to achieve, much of what we've discussed already today. The findings from the beta so far, with a couple of interactive graphics, one for a line chart where you can explore the results for the time series at England level, and one an interactive map, so you can look at the different levels of the index at UTLA geography and see how it differs geographically and notice those inequalities. Alongside this, we put out a blog introducing it, a technical report detailing all of the methodology we've just covered and the data selected, including information on data we didn't include because we think it's relevant to health, but we couldn't find an appropriate source. And similarly, if there were methodologies we thought were appropriate or we thought would be useful, but weren't appropriate given its current structure, we've listed those as well. And most importantly, we put out the data. While everything here is still very provisional at present and will change between now and the full version released this summer, it it means people could use that to illustrate the types of analysis they could achieve using the health index and its structure. The most exciting part of all of this is, though, that Lane Clark Peacock, the actuarial group, worked with us to create an interactive web tool for visualizing the index, which I'll show you in just a moment. And on Citizen Space, alongside the launch of the beta article, etc., we launched our public consultation, which is running for 3 months, so we'll close on 3rd of March, asking the public and analysts to give us input into how the index looks to them, how much it meets the aims that the original concept was angling for, and what suggestions they would make for changes or improvements. Alongside that, there's a consultation document on that page which summarizes much of what's in the ONS materials elsewhere. So now I'm going to try to share screen, and hopefully that will work okay. We might need to re-upload the presentation afterwards, but that shouldn't take too long. Please, someone let me know when you can see the Health Index Explorer screen.
Yep, that's fine.
Brilliant. Thanks, Maya. So this is healthindex.lcp.uk.com, which is where Lane Clark Peacock hosts their Health Index Explorer. It has various different functions. You can click on an area and explore that immediately. So, for example, if I click on East Midlands, you can very quickly see through the colour shading how different UTLAs within the East Midlands are doing compared to each other, and immediately get a ranking for how the East Midlands is doing on the overall index compared to the other regions. But you can explore geography in more detail using the map function on the side, and anything you go into, I normally end up gravitating to any outliers like Nottingham there. Sorry, let's go back in. You can immediately see how they're doing compared to other UTLAs with similar ranking, and you can see for the index as a whole what their overall score is and what their scores are for each of the 3 main domains. You can also visualize the index as a whole through this sunburst chart, where at first we're just looking at the index as a whole, and you can change which year you're comparing to, with 2018 as the current. But this innermost area is represents the 3 domains. So we've got healthy people, healthy lives, healthy places, and within those you can fan out to the different subdomains to focus on the topics of most interest to you, and the different indicators within that, so you can access whichever level of the index is most interesting for you to investigate and see what the geographical inequalities are. As well as this, there are tools that LTP have included for producing your own charts. The simplest of which is a time series, where you can select which part of the index you want to look at, and whether you want it to be a regional time series or a single value for national. So you can very quickly compare not just regions' absolute scores, but how they have changed over time for different parts of the index. And the best part, if you ask me, is these scatter plots, where each of these data points represents a local authority, and you can plot different parts of the index against each other to see how they're correlated. This isn't just limited to the index. We've included in here measures of population size and seeing how whether or not there's a correlation there, the median age of the local authority, and their index of multiple deprivation score. So the current chief medical officer is very keen on the idea that health at the moment is driven by the age of a population, the deprivation level of the population, and the interaction between those two, and being able to look at different levels of the index and see how they relate to these 2 factors really helps us unpick some of those stories. This might be a particularly obvious one, but there isn't much correlation at all between IMD score and index scores for dementia by local authority. But if you change that to age of population, immediately there's a much more clear correlation. And you can also add a 3rd dimension to these charts by weighting each data point by their population, or by which decile of the IMD they are in. so you can understand very quickly some of these interactions between age and deprivation, or population size and age, and these sorts of things on different indicators. There's also information here about the index as a whole. The first time you load up the website, there's an introductory video explaining how you can, all the different things you can do with it. And there's information which signposts you to ONS's published materials on the index as well. So there's an awful lot here, lots of exciting things to compare and contrast within all levels of the index. So you can map the high level index score itself, or any of the domain scores, or the subdomains, or any indicator as you so wish. So next we want to cover what we're doing next, take any questions from you, and also direct some questions to you, telling you the main things that we're trying to find out in this consultation period. So as I've mentioned, on the 3rd of December, we released the Health Index beta for the first time and launched our public consultation. That consultation is open for 3 months, during which we're promoting the index with webinars such as this. And then within 12 weeks of the consultation closing, we'll publish a summary of the consultation responses. So that's the you said part of the you said we did contract. In summer this year, we're aiming to release the full health index, building on the improvements we've made during this consultation period, the feedback we've received in the consultation itself. And one of the benefits of putting together all of these health indicators into a consistent format for producing the index is we've also, by design, overcome one of the biggest hurdles of creating any sort of health model, in that getting your data into a nice format for modeling is one of the biggest issues that people will face when building a model on any topic. So we're aiming to produce and release a very flexible health projections model, so people can see if they change one aspect of health, what impact that has on others and how that looks into the future. And as a byproduct of this, we'll also be producing baseline projections for, in the absence of intervention, how will most of these indicators look into the future, which for many of these topics will be the first publicly available projection of their trajectory. So that'll add value even before the additional information that that model will provide. So this is something we're planning to release a first version of with minimum viable spec, and then develop it iteratively following user feedback. Longer term than this, we have other plans. We're developing, hopefully, a Health Index UK in conjunction with the devolved administrations, and speaking with OECD about how the Health Index framework here could be applied internationally. One of the benefits of us having topics rather than being too prescriptive with specific indicators means that other countries could map the data they have available to the index structure as a whole, even if they can't match the exact indicators, to hopefully produce something comparable. And we're also exploring what it would take to produce a more frequent version of the health index, because right now it relies on a lot of annually available data, and it might be that we could estimate index scores using the data points that are available more regularly, but this is something we need to explore a bit further. So the main things that we're asking within the consultation, there are more beyond this, but overall it's does the concept of a health index seem sensible to you? And do you think that what we are doing here meets the needs of such a health index? How likely would you be to use it for your own analysis, and what sort of things would you like to use it for? Is there anything about it that you'd like to change, whether it's the conceptual structure of domains, subdomains, and what's in those, or the methodology of how we've combined it? How would you want others to use it, especially there, I suppose, thinking about the media, but also if you're aware of particular organizations who can make good use of it. And finally, we should be able to present a version of the health index very similar to the beta at lower tier local authority level, at least for the full version this summer. Without promising anything, we're still exploring this. But it may be that to present lower geographies or present it more frequently, this would be at the expense of some of the breadth of indicators we're presenting at the moment. So it would be interesting to understand how much your needs rely on it being available at a lower geography or more regularly to be useful for us to understand whether those topics are worth us exploring. But yes, with those questions in mind, that's the end of what we're formally presenting today, but we're very happy to take any questions. And I see, Maya, you've already answered a couple in the chat.
Hi, Greg. So I'll be I've been looking at the chat, and Maya did kindly answer a question that came in earlier. So firstly, I just wanted to say thank you so much for sharing all this fantastic work. It's very exciting, and I would, for one, definitely be participating in the consultation. So great job, and thank you so much. We have a question in from Richard, who asked, how sensitive is the overall index at national and local levels to different weightings of the domains?
Thanks, Hira, and thanks, Richard, for that question. At present, it's not hugely to individual domains, and this is something we want to explore further once we've got subdomains weighted the way that we intend for them to be, rather than equally weighted. Right now, it's sensitive enough that you can see some trends based on the domain scores and then dig into those further. So, for example, on the surface of it, the health index score doesn't look like it has changed much over time at all in the 4 years that we're presenting. But if you look at the domain level, you can see what this is driven by. The healthy people, so the more health outcomes part of the index, and healthy places have both been declining slightly but steadily over the 4 years that we're presenting. And healthy lives, the individual circumstances, have actually been increasing over that time, and been increasing quite with quite a high gradient. So they've been dragging the index back up, even though it only represents 1/3 of the overall, and the two which are declining represent 2/3. But it's in the latest year that healthy lives has not increased in the same way we've seen so far, and had a slight decline in its score at national level, and this has led to the index as a whole dropping. So on its own, that's a sense check that the index is sensitive to change in one direction or another, and then we can look into which aspects of healthy lives are driving this. But we're going to explore that even further once we've got the subdomains weighted in the way that our ideal methodology would include.
That was great. Thank you so much for that, Greg. That's a great explanation. We also have another question coming in that came in from Nicola. So she asks, how do we move from correlation to understanding causalities?
There are a few different bits to this, and again, this is something that we're investigating at present while building our health projections model using these data. Parts of it are in a more qualitative way. We can know where some local authorities have introduced an intervention for certain topics, such as if they've made a specific improvement to access to services, and we can look at the time before and after that improvement, and what that's meant for the indicators which we expect would be related to that. So, for example, we can see information on knowing when changes were made to sugar taxation. We can see a noticeable shift in the childhood obesity indicator following that, which suggests there's a causation there. On a simpler level for our modelling, we're also looking at the time lag between if there are two areas which are correlated, how long before one follows another, to use the order in which they occur as a way of identifying causality. But yes, this is a topic that we know we'll need to understand better when it comes to the health projections, because we won't want people to make a change in one direction and for it to affect something which normally drives that variable based on correlation rather than causality.
Can I add to that? This isn't an analysis tool. It's a tool which allows people to see trends and patterns and correlations. Obviously, when you want to do analysis, you need to use methods which look at things like longitudinal change and allow you to infer causality. And that's simply not what this type of indicator is for. I'm just thinking back. I think some of you who are also of my generation remember the original NHS performance indicators, which allowed all kinds of digging into correlations of different kinds on various different health-related and health service-related things, and they always came with a big warning on the box, which said these don't give you any conclusions; they just give you a starting point for investigation. And this really is the same thing. No set of indicators gives you causality. It gives you trends to observe and differences or correlations to investigate using whatever are the appropriate methods.
For the explanation, both Greg and Maya. We've also just had another question come in from Caroline, and she mentions, for measures such as hypertension, which increase with age, is this an example of where you've used incidence rather than prevalence? I'm trying to understand how or if expected aging of the population would show on the health index.
I believe that's one of the places where we've used incidence rather than prevalence, but I will need to confirm. I can quickly look that up in just a moment. It's not one I know off the top of my head. There are some questions overall. This isn't specifically answering that question, but just thinking about one of the issues we're investigating that may be of interest. I mentioned in the factor analysis we had some non-thematic correlations occurring and groupings into factors based on rural-urban split. Similarly, we noticed those trends for variables where we were able to age standardize a condition, which we thought was an improvement to make sure we're measuring health rather than age, and indicators where we couldn't age standardize because that measure wasn't available. So this is something that we've been taking into account where we can in our indicator selection as well, because we think that, again, if we want to measure health fully, then we need to be able to control for age. And we can partly do this using the LCP Explorer tool, where we can plot different things and different parts of the index using the median age of the population to get a sense for how much they're led by age and how much it's controlling for age already. But this is something that we're keen to find more sources where we can age standardize to make sure we're measuring that in the right way. I will now very quickly look up for hypertension specifically, whether it's incidence or prevalence, so I can confirm that for certain.
Can I just say that we're going to save the chat and offer the speakers the opportunity to edit what they've said verbally. So obviously Greg will be able to respond to that, and then we will then put that on the RSS website.
Yeah. Should I move on to the next question? So we've had a question come in from Paul. Would it make sense to show expected variability around each indicator?
Yes, especially once we're projecting into the future. One of the difficulties of this is that each of the indicators is measured in a different way, and we've collected them from a large variety of different sources. I think overall, of our almost 60 indicators, we're using about 13 or 14 data producers. So how we would present that variability and what those levels of variability would be will vary quite a bit between different indicators. So for a more statistically minded audience who would definitely understand what we're doing by showing that variability and uncertainty, I think that will be very valuable, and it's something we can explore for our future data viz. But for the simpler tools for visualizing the index, we want to keep those as clear as possible as to what's being measured, which may in fact mean that we should be presenting that variability. But unless we can find a way to present it consistently for each of the indicators, which would be meaningful, that may cause more confusion given the nature of the index than it would improve.
I would add to that, we're committed to making this extremely transparent. So there isn't just the index and its visualizations. There will be the ability for more advanced users to download, sheets of spreadsheets or data sets of the data and metadata about all the measures, and therefore what we know about variance, confidence intervals, and all the rest of it. I think that's extremely important. I'm less keen, given our aim of producing something which is easy to visualize and people can, of all kinds, not necessarily statisticians, can look at and understand. I'm less keen to complicate the presentation.
That's perfect. We've just had another question come in. So Nicola's asking, when one starts predicting, what validation methods will be used for making the predictions and looking whether they were accurate?
Again, this is something where we have a couple of ideas in mind. One is that right now we're investigating as a pilot area the sugar tax and seeing how a change to levels of sugar tax might impact obesity and how that might in turn impact prevalence of related conditions and what that would mean for health. So in one sense, we can look at existing literature and ensure that the effect sizes that we're presenting are meaningful compared to people who have analysed these topics in more detail. But also, by nature of the health index continuing into the future, we can use the data points we have now to create some projections and then compare them with future years of the index as those come in and the different indicators within the index to see how reasonable our baseline projection is. As mentioned, so far we're on a 2015 to 2018 time series at present, which is 4 data points minimum for the indicators that we're presenting. So we're not expecting the linear projection or a linear extrapolation of those to be particularly accurate because it is only 4 data points. But this is something that we're expecting will improve over time the more data points we have within the index. So making those comparisons for internal consistency with later years when they're available and with the analysis that others have already produced should allow us to check that what we're doing is accurate and meaningful.
I don't think this is something covered by the consultation because there's really a separate project going on in which Greg's team are working on developing what we're calling a lightweight health projection model, which can be applied to the index and to a number of various different scenarios. And obviously we'll publish information about that when we're at appropriate point in that project. But that will go through all the usual kind of protocols you'd expect when you're validating a projection model, like testing on various past data sets, etc.
Right. Thank you very much. What I've just done is gone back to the slide of the key questions, and we've got to the end of the questions in the chat. But if anybody would like to ask any further questions, can you please use the hands up facility, which you can see on the toolbar at the top of your screen. Has anybody else got any questions they want to ask at this point? It looks like the answer is no. Remind you that we're going to put the presentations, which will include the questions, on the official statistics section page of the RSS website, so that anyone that's missed this or wants to go back to anything. To remind you that the consultation closes on March the 3rd, that ONS is keen to hear from you. Our speakers aren't necessarily expecting a great long essay in the answer to each question, and you don't have to answer with all the questions. They're just interested to hear the views on what they have circulated so far. So I think what it remains for me to do is to thank our speakers for their presentation today, and to thank the RSS for hosting the meeting. Thanks Luz Martinez, who's done all the work behind the scenes, and thank Kira for facilitating the questions. And hope that will stimulate response, and please pass the message on, because I know people are busy. So those who haven't had time to take part in this webinar know that the materials will be online. It's not too late. We have 3 weeks to go for the response, so please make sure you make time to respond. And meanwhile, thank you very much for attending today.